Thank you, Louise, and welcome everybody. And thank you very much for the invitation from Tipton Training to speak to you this afternoon. So my three messages are: let's keep safe, let's keep interested, and I would like to credit Tipton Training with the idea of running these free webinars to keep us all on our toes and keep the brain working while we can't do much else. And let's all keep going. That's useful. So keep going. Things will get better. We have to believe that. So that is a church that is on the A55, which is a major trunk road that runs from where I live in the northwest of England, Manchester, to where I like to go when I can, which is North Wales. And it's known as the Marble Church for obvious reasons, and it's very pretty. And the graveyard is full of young Canadian soldiers who, after the First World War, were struck down while they were in a nearby barracks with what's known as Spanish flu, but more accurately is H1N1 virus. So that was the last pandemic, just over 100 years ago. And to put it into context of what we're suffering now, that infected 500 million people and 50 million people died. And to give us some idea of how far we've moved on since that previous pandemic, it was only a few years later that they realized that why some soldiers, who were all confined to barracks, of course, some soldiers or some regiments did worse than others in terms of deaths. It was because it was dependent on how close the beds were together in the barracks. So my name is Stephen Davis, as Louise said. I teach at the Manchester Dental School. I teach the 4th and 5th years students, and also I'm involved in most of the MSc programs, including the distance learning MSc in Advanced Restorative Dentistry. So I also have a foot in primary care. I'm a specialist in restorative dentistry in a referral practice in primary care. I'm the lead clinician, or actually one of now 2 lead clinicians of the Temperamental Disorder Clinic at the University Hospital. And as I say, I'm a lecturer. So I've managed to pursue just about 2 careers, one actually doing it and one talking about it. So I've published 55 peer-reviewed papers, and I'm a co-author on 2 BDJ books, one of which has some relevance to what we're talking about. Well, actually both do a little bit. Oh, I should go back. That's how my granddaughter, age 5, saw me. And when my daughter, her aunt, saw that picture, she said, Dad, she's been generous with the hair and the legs, because I haven't got a lot of hair and my legs are quite short. Anyway, so that's a little bit about me. I'm happy for you to contact me at any time. That's my email address, or I'm contactable through Facebook as well. Something I always do ask is that if you contact me, it's always nice to know where we met or when I talked to you and about what, because that puts it into context. I'll be happy to make available a PDF version of this lecture, which Louise will be able to send out to you. And now that Louise has explained that this is a webinar rather than an interactive lecture, I understand that questions will be at the end. That's fine, so that you don't need to have your microphones turned off. Something I'm afraid that is very important is that I'm privileged to have a certain number of patients who have agreed to make statements when I'm talking to dentists about their experience, or to subject themselves to various examination procedures, etc., etc. And all of those permissions were given on the understanding that they would not be shared with the World Wide Web or anything else. They were really designed for closed meetings. So I do need to remind everybody that to record this lecture by any means, especially the bits that contain patient statements, is actually illegal under the Data Protection Act of 2018. So I would be grateful for everybody's cooperation in that. So the title is Occlusal Considerations or Good Occlusal Practice in Periodontology. And the occlusion booklet, which was published by the British Dental Journal in 2002, had various chapters, and chapter 7 was Occlusal Considerations in Periodontology. And that is now being rewritten. It's very nearly finished, and it should be published in 2021 by Springer Nature publication. And I'm very fortunate to have Professor Kevin Seymour, the Professor of Periodontology at the Manchester Dental School, as my co-author on that particular chapter. So in many ways, at least the second half of what I'm going to be talking about in this lecture, which is, I'm afraid, going to be rather a long one, I'll explain exactly why in a minute, has been through a pretty rigorous peer review process by virtue of the fact that Professor Seymour was my co-author. Now, the reason why it's going to be quite lengthy is that I have to, well, I feel I have to give some background to how I'm going to approach the subject of occlusal considerations in periodontology by giving you some of my views, and they are only my views, on occlusion and which context we should put that into and how and to examine and record it. You can rest assured I'm not going to go through a simple restorative dentistry, etc., 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 but I'm going to go through the first bit of that presentation. So the first bit of the lecture is going to be kind of a background, or for some of you, I'm sure it will be revision. I hope it won't be heresy for any of you, but it's no problem if it is. These are only my opinions. So in that, I'm going to be looking at the components of the articulatory system, how we might examine the articulatory system, try to answer the question, what is occlusion, and how to do an analysis of it, and think also about ideal occlusion and malocclusion. And then the second half of the lecture will be specifically about periodontology. We'll look at some definitions, and we'll ask the question, does occlusal trauma have a role in the etiology of periodontal disease, and therefore should it have a occlusal therapy, should it have a role in periodontal management? And then we'll look at some examples of occlusal therapy that have come from my own practice, where I felt there was some justification in their inclusion in the patient's treatment plan. So we all went to good dental schools, and we all learnt everything there was to know about two parts of the stomic-gnathic or masticatory system. There isn't anything a fifth-year dental student doesn't know about teeth or about the periodontal system, but it seems to be the case that almost all over the world that not a lot is taught about the articulatory system. So here we have a system that is itself made up of three other systems, and I want us to get the concept of systems into our head a little bit. So that's the masticatory system. And then in a bit more detail now, let's look at what makes up the articulatory system. And the articulatory system is made up of the temporomandibular joints, the muscles, and the facial muscles, or muscles of mastication if you prefer, and the occlusion. And that's what we call it because we're dentists. But if we were engineers, we'd say that this system is made up of hinges, motors, and contacts. And that's pretty useful because it tells us exactly what each component of the articulatory system does. And I think that considering the articulatory system as dentists is important because it is where we go to work. Everything we do to patients, we do within the articulatory system. I'm primarily talking about restorative dentists, aren't I? So if that is an important aspect, then surely we need the ability to examine it. And that is the very basic, the very first attempt we made at giving people a protocol for examining the articulatory system, the muscles, the joints, the muscles, and the occlusion. And that was in that book. And we've moved on a little bit since then because this is the one that I use in practice and that we use at the TMD clinic at the Manchester Dental Hospital. And I'm very happy if anybody wishes a copy of that for you to email me and request it, and I'll happily email a copy of it back. And we're going to go through that now, and you're going to see us examine somebody using this protocol of the examination of the articulatory system.
So let's do an examination of the articulatory system, made up of the temporomandibular joints, the muscles of mastication, and the occlusion. So the joints, first of all, are they tended to palpate? Do they make noises? And do they move normally? Ask your patient to open and close a few times, just to establish where the lateral aspect of the head of the condyle is. Stay closed for me now, and you just press fairly firmly on that. You can also examine from interauricularly with a little finger, pressing forwards on both sides. Now let's have a listen to it and see if it makes any noises. We're looking for clicks or crepitus. So open wide for me. I'm using a stereo stethoscope, and close again. Stereo stethoscope here, and we're not hearing any clicks or crepitus. You can use a mono stethoscope, that's no problem. The quantitative assessment is done simply with a ruler, and ask your patient to open wide and measure. I measure incisive edge to incisive edge, and there's 40 millimeters, and there's a bit of an overbite as well, but I just measure incisive edge to incisive edge. We can also look at the qualitative assessment, and we have a close look here. Open wide for me, and we can see that there's a fairly straight opening there. It's forming a straight line, indicating that the head of the condyles are translating at the same speed and to the same point. Now the muscles of mastication, the right masseter muscle, open for me, close together, and we can just roll that muscle between two digits. There's no tenderness there. Same over on the other side, close together. The temporalis muscle is very easy to palpate because it's fixed to the side of the cranium. The anterior fibers first of all, and then the posterior fibers. The lateral pterygoid muscle can't be palpated. It's not accessible for palpation, so we do a resisted movement test. We hold the patient's head quite firmly and ask the patient now to slide their jaw towards the right hand side, teeth slightly apart. And now, holding the head firm, we ask our patient to resist us trying to push their mandible back with just the mandible. And the side that's going to hurt is the other side, on the left hand side. Sliding it now away from me over to the left, and we pull it back the same way, and I emphasize that it's going to be this one that is going to be tendered to this resisted movement test. The occlusion, we're going to see whether centric occlusion occurs in centric relation. For that we have to palpate, we have to manipulate the patient into centric relation. Just lift your chin up for me. The fingers want to go on the lateral aspect of the lower border of the mandible, and then you can roll your fingers down. If you start on the lower border and roll into the sublingual space, that's uncomfortable. So you want to hold firm and move gentle. Just let your jaw fall open for me, and we're looking for a fairly perfect arc, a neuromuscular release, nice and slack, let it fall open again. And we're now tapping up on the premature contact, which is in the left premolar region, just there, and we ask our patient to slide together, and from that premature contact there's a slide that is anterior and slightly to the left with a vertical dimension as well. Now we're going to have a look at the anterior guidance, and for this we want to see whether there are any posterior interferences. So we put the paper onto this side, which is going to be the non-working side, and ask our patient to slide the mandible to the right hand side, teeth now in contact somewhere. And you can see and hear that the paper is firmly bound between a posterior interference on the non-working side. Just keep sliding as well as far as you can. Keep going, keep going, keep going, keep going, and even further if you can. It gets progressively more difficult for the patient to slide. Open wide again for me. I'll have a look on the other side, close together, slide over to the left hand side, and even in that extreme position, which is called the crossover position, because the lower canine is cross-buckled to the upper canine, we still have, as you can see, a non-working side interference.
So since I recorded that, there have been some changes. We no longer stick our finger into people's external auditory meatus. It was always part of the European protocol, but actually we never particularly believed it in Manchester. We think it hurt because you're putting a fairly big finger into a fairly small space. But now, instead of that, we ask the patient when we palpate the lateral pole of the temporomandibular joint, whether that is causing the familiar pain. Secondly, if there's an intermittent click, we write down whether that is intermittent with normal silent opening or intermittent with closed lock. We look at also whether a limited opening can be improved by passive stretching. And similarly to the joint tenderness, we ask the patient whether any muscle palpation is mimicking their familiar pain. We also, in terms of, not on the clinic, but in terms of practice, if you're a restorative dentist, you're interested to know whether the slide from the premature contact to centric relation to the patient-centric occlusion, and I will define these terms, so don't worry if I'm not using the terms that you're familiar with, whether that slide is mainly vertical with a small horizontal component or mainly horizontal with a small vertical component. Because if we are looking at the possibility of equilibrating somebody, it's much more difficult. This is Michael Wise's work, if it's the large horizontal component.
Okay, so what we're going to do now is a compression test, trying to determine whether the pain is mainly coming from the joint, arthrogenic, or is mainly coming from the muscles. And if we ask our patient to just bite on a couple of tongue spatula and bite as hard as you can, and if he complains of pain on the other side, you can imagine, can't you, that as he's biting here, this joint is being compressed. So pain that is on the contralateral side is suggestive of arthrogenic pain, whereas if he complains of pain on this side, it's more likely to be myogenic. And then we just swap over the other way, bite together tight. And to say again then, this pain here is this actually hurting, Matt?
A high bit or not high?
Okay, we tried to choose Matt as one of our practice staff who's least likely to have anything wrong with him because he goes to the gym about every 10 minutes. But obviously we got it wrong. So here we go. Pain on this side is arthrogenic pain, and pain on the same side is myogenic pain.
So that's a very useful test. It's called the compression test. Parker Mahan's in Florida devised that, and it will give us the indication whether pain in the preauricular region is mainly myogenic or mainly arthrogenic. So what is occlusion? So occlusion is the third part of the articulatory system, and we know already, don't we, from the engineer's analogy, that it means the contacts. It's the contacts between your teeth. And to make it even easier, we have contacts when we just close our teeth together, the static occlusion, and contacts when we slide our teeth over them, each other, and that's the dynamic occlusion. So nothing could be easier than defining occlusion, which is strange because it causes more arguments in dentistry than almost everything else. So why is it that there's such controversy and confusion around the subject of occlusion when it simply means the contacts between our teeth? And I think there are three reasons for that. Firstly, lots of people like rules. They would like to be given and adhere to a single occlusal philosophy. Secondly is the whole subject of terminology, which is a complete and utter nightmare in occlusion. And thirdly, that within the dental profession, there is an enormous variance in opinion of how important occlusion is. So occlusal philosophy, well, there's no shortage of those. But basically, if you believe that all occlusions or all of your restorations should be done to a particular occlusion, and some occlusions are right and some occlusions are wrong, then you're looking at things from a mechanical point of view. It's almost like an engineering model. Terminology, well, the glossary of prosthetic terms, those of you who study this will know that every time they bring out a new edition, they change the definitions that are relative to the occlusion. In terms of the range of opinions on the importance of occlusion, we've got dentists at both ends of what is a fairly wide or tall spectrum. We've got dentists who believe that occlusion is somehow the key to musculoskeletal harmony throughout the whole body. And we have other dentists who believe that they can basically ignore occlusion. Oh, I don't do any of that occlusion stuff. I remember meeting a colleague of mine who I qualified with probably about 20 years ago now. And he said to me, oh, hello, Steve. He said, I hear you're into occlusion now. And it was said in the same tone of voice as if I just joined the Moonies. So I was surprised because I thought all dentists, all restorative dentists were into occlusion because there's very little you can do to people's teeth that doesn't involve the occlusal surfaces. So those dentists will just go through with their fingers crossed, maybe hoping that the occlusions that they provide in their restorations don't upset the patient's equilibrium in some way. And then there are others who believe that it's got this kind of mystical importance and you can correct people's lumbar spines by adjusting their occlusions. There's some cases of the sort of thing that I've taken from the non-refereed journals as to what occlusion can cause. But of course, the basic truth is that dentists can't move, remove, repair, and replace teeth without being involved in occlusion. So it is something in some form all of us have got to take some interest. I would tell the dental students, and it's never a welcome message that I give, especially to the fourth years who are still struggling with all sorts of aspects of clinical dentistry. I will tell them there is no escape from occlusion. So if there is no escape, maybe we need a way of being able to examine it fairly easily. So let's look at how we might do an occlusal analysis. And I promise you, I haven't forgotten the title of this talk. We will get there, but I hope you see the reason why we need to go through the foothills first before we get to the higher ground of occlusal considerations in periodontology. How to do an occlusal analysis? Well, here's the occlusal aspect of the articulatory system exam, and the first question it asks itself is, does centric occlusion occur in centric relation? Apologies, because I'm using those terms and they may not be your favorite terms. So what do we mean by centric occlusion? I don't mind what we call it. Call it anything you want, but what it is, it's an occlusion. It's describing a tooth relationship. It's how we fit our teeth together. It's how a technician will put models together when they're just handheld. Whereas centric relation has got nothing to do with teeth. People who don't have any teeth still have centric relation. In fact, it's one of the first things you try to find for a patient for whom you're going to make complete dentures. And there's all the synonyms again, but let's not worry about those. It's a jaw relationship. And it's a jaw relationship that can be described in one of three different ways: anatomical, geometrically, and conceptually. So anatomically, it could be described as a position of the mandible to the maxilla with the disc in place when the head of the condyle is, and that's when the arguments start. Some people will say it's uppermost and rearmost. Others will say uppermost and midmost, because that looks quite neat on a corrected transcranial radiograph. And other people believe it's uppermost and foremost. And I'm probably one of those. I believe it's in the position of the head of the condyle is in its most superior position against the distal facing incline of the glenoid fossa, which is an uppermost and foremost, and that's more due to anatomical observation than any philosophical dogma on my part. Because does this matter? Absolutely not. Whichever you think it is. It always amuses me that they sort of push the mandible upwards and backwards. The uppermost and rearmost is remarkably similar to a wrestling move in that sort of American worldwide wrestling thing. It's called the mandibular claw. But we can't see where it is, and therefore it doesn't really matter where it is. Now let's look at what we might call a geometric definition of centric relation. And for this, we have to go back a long way, back to Possett's envelope of movement, which some of you will be familiar with. And if you look at the first bit of Possett's envelope of movement down there on the diagram, the red arc, that's the bit we're interested in, because that is taking us from centric relation to centric occlusion. And you'll notice that it's a perfect arc. And the reason why it's a perfect arc is that the center of rotation of the mandible is stationary. That is to say, the TMJ is in its rotational phase of movement. It hasn't started to translate. That is to say, it's the beginning of the opening cycle or the end of the closing cycle. That's what we want. Let's just call centric relation the beginning of the opening cycle or the end of the closing cycle. That for me will do. And clinically, it's a useful observation as well, because we can get a feel for that when we're trying to gently manipulate. I don't forcefully manipulate patients when I'm trying to find their jaw relationship of centric relation. So it could be called the terminal hinge axis. Conceptually, position of the mandible to the maxilla with the disc in place when the muscles that support the mandible are the most stable and least strained. And if I may, I'll ask you to hang on to that concept because we will come back to it when we talk about ideal occlusion.
Just open wide, and now just close your teeth together normally for me. In that position, with the patient's teeth all touching in centric occlusion, we can see that we've got what appears to be a quite normal overbite-overjet relationship. Right, what I'm now going to try and do is to find centric relation. I gently take hold of the mandible, but I'm not going to force it back. Right, Beverly, I'm just going to move your jaw up and down. Just concentrate on let me opening it for you. Just let it go completely slack. Try to relax everything off. I want all the muscles of your jaw to relax. Centric relation is a muscle-free position, and it's no good substituting my muscles for hers. I mustn't force her into any position. She'll tell you, if I give her a chance, that this is very, very light pressure. And I'm slowly going up until somewhere her mandibular teeth will touch her maxillary teeth, and then we'll stop. Right, we now have some teeth touching. I don't want you to tell me just yet where that is, Beverly, but think about where you are hitting, and just let your lower lip go quite relaxed. There I am. I'm tapping on the premature contact in centric relation, and you can see now that we have a quite definite space between the central incisors. We're in centric relation. And if we ask the patient now to indicate with a finger, just touch your chin on whichever side you can feel that premature contact. Mm-hmm. So just do that again for us. You're touching the right-hand side. Okay? We're holding that on centric relation in the premature contact. And if we now watch closely again, we'll ask the patient to squeeze her teeth together. Okay, that's it. And she slid then anteriorly and slightly to the side from centric relation to centric occlusion. Just do that once more.
So let's move on, because when I do it again, it's exactly the same. So that's really dealt with the concept of the static occlusion. Now, what about the dynamic occlusion, the contacts that we make when we slide our jaw from side to side or front to back? And the key phrase here, isn't it? It's anterior guidance. And you could ask the question, where is the anterior guidance? Is it on front teeth? And some of you would think, well, of course it's on front teeth, dummy. It's on front teeth because it's called anterior guidance. But let's just step back from that a little bit and say, what's being guided by anterior guidance? And the answer, of course, is the mandible. That's the bone that moves. And if there is an anterior guidance system of the mandible, is there a posterior guidance system of the mandible? And the answer is, of course, they are the temporomandibular joints, because you don't get further back than that and still be the mandible. So I cannot escape from the conclusion that whichever teeth touch during an excursive movement is for that patient their anterior guidance. Because all of those teeth, no matter how far back in the mouth they are in front of the posterior guidance, namely the temporomandibular joints. Which is interesting, because that means that in dentistry, we discriminate against anterior guidance that's on the back of the mouth by giving the prerogative term of interference. So we call them posterior interferences, which begs the question, with what is it interfering? And let's try and attempt to answer that.
So in trying to define what we mean by anterior guidance, let's consider what is the posterior guidance system of the mandible. Well, they are, of course, the temporomandibular joints. And if you accept that the anterior guidance is provided by whichever teeth touch during excursive movement, because all teeth are anterior to the posterior guidance system, the temporomandibular joints, we have to ask ourselves, why in dentistry do we discriminate against anterior guidance that happens to be on back teeth by using the term interference, as opposed to the guidance that is on front teeth, where we talk about something like canine guidance. Why do we discriminate against anterior guidance that happens to be on back teeth? The nearest I can get to an explanation is a visual one. Imagine, if you will, that my fists are the head of the condyles of an imaginary mandible in front of me. If we ask this mandible to open, we know what will happen is, first of all, rotation and then translation. That gives us a normal mouth opening. Now, if we consider what happens when we ask this imaginary mandible to slide to the right-hand side, essentially we say to this joint, don't open. Ignoring immediate side shift for a minute, we'll say stay closed. This, somewhat confusingly, is called the working side, whereas this, the side that opens during a right lateral excursion, is termed the non-working side. So imagine, if you will, this is the non-working side during a right lateral excursion. Rotation, translation. If we have a tooth that is attached to this bone, the head of the condyle, that is just there, obviously the second molar, and another tooth that is attached to this bone, the glenoid fossa, obviously the upper second molar. Imagine what happens during this movement of the mandible. Here's the posterior guidance, and here is the anterior guidance. These are the only teeth that touch during this excursive movement, and they are universally known as non-working side posterior interferences. Would it not be more ideal if, instead of these two teeth providing the anterior guidance, we had two flatter, slab-like teeth that are, importantly, much further away, namely the canines on the other side of the mouth? It seems to me to be mechanical common sense that if you wish to interfere with the movement of something, namely the temporomandibular joint, get close to it. And that is why I believe it is considered to be more ideal for the temporomandibular joints if the anterior guidance is provided further away by the contralateral canines.
So we probably have got to the point now where we can answer the question, in some way answer the question, what is ideal occlusion? We could say, for instance, do you think it might be ideal for some patients at some time in their lives if their teeth fit together in the position of the mandible to the maxilla, when the muscles that support the mandible are at their most stable and least strained? And for some patients, at some times in our lives, that might be ideal. And we could say, would it be more ideal when the patient slides their teeth from side to side that the anterior guidance is as far away from the posterior guidance as possible? So we have got to a definition of ideal occlusion. And specifically, we've got to the definition that was given in the first edition of Bramford and Ash's book entitled Occlusion. And they defined ideal occlusion as the anterior guidance on the front, at the front of the mouth, no posterior interference is another way of saying the same thing, and centric occlusion occurs in centric relation. And that could be considered to be ideal for the muscles, whereas the first one could be considered to be ideal for the temporomandibular joints. And as I say, that first edition, which was all the way back in 1983, that's how they defined it. Let's move over freedom and centric occlusion for a minute. We'll just stay with those two bits of that definition. So that's good, we got there, but they changed the definition in subsequent editions of the same book. Out went that mechanical definition, and they brought in a new one that said ideal occlusion is a state in which there are no neuromuscular and other, I've added the and other, adaptations needed because there are no disturbing occlusal relationships at present. So now look what we're doing. We're now judging an occlusion by the tissue reactions to it. And I'm getting a bit closer to good occlusal practice in periodontology. We're now judging an occlusion by the tissue reactions to it. And we're saying if there are no adverse reactions, that occlusion is okay for that patient at that time in their life. That is their ideal occlusion. So we've looked at and why we might have got to the original mechanical definition, which still has a role in particular in the reorganized approach in advanced restorative dentistry. We've looked how we got there. Now let's turn that coin on the other side and look and say, what is malocclusion? Because that's kind of answering the same question from a different way. What is malocclusion? And here I'm getting into dangerous ground, because I'm going to stick my head above the parapet and say there is no such thing as malocclusion. It doesn't exist. I wrote a bit in the BDJ to say it doesn't exist, or in my opinion, we should revise it. And I think instead of the term malocclusion, which literally means bad occlusion, let's introduce, and it's not my term, let's introduce the term maladaptive occlusion. In fact, Henry Gramillion, who unfortunately has just died, introduced this term, maladaptive occlusion. And what he's doing here is that he is saying we judge an occlusion by the patient's reaction to it, their lack of adaptation to it. Because we are not oral engineers, the amount of restorative dentistry we do requires sometimes an almost engineering attention to detail, but we're not oral engineers, we are oral physicians. If somebody has a very mechanical view of occlusion, I can be very rude to them by saying, I think you have a mechanistic view of occlusion. And it's very rude because Professor Greenfield in her book defined a machine as a system that is not the result of a fertilized egg. So if we're treating patients in a mechanical way, it probably is a bit limiting. So a maladaptive occlusion may affect the tissues of any of the tissues of the masticatory system. It may affect teeth. We see abfractions, we see wear, we see fractures, we see migration. It may affect the articulatory system. I spend a lot of time treating patients with myofascial pain. I am not saying occlusion is the cause of that, it's a factor. Disc displacements, osteoarthrosis, conditions of the temporomandibular joint, they're all quite capable of having an occlusal element. But the big question mark, the one that we're all addressing this afternoon, is does it affect the periodontal tissues? Okay, so if it is that an occlusion, that the patient can have an adverse reaction to their occlusion on all of those levels, surely it's important that we can examine the patient on all of those levels. And we're now back to where we started, which is the importance of being able to do an articulatory system exam. We know how to do dental and periodontal exams. So a couple of examples of adverse tissue reactions in respect of occlusion on the tooth level. I've given you some of those. Let's have a look at some. We've got abfractions, which are loss of tooth tissue due to an occlusal etiology, but occur distant from the point of occlusal contact. All sorts of theories as to how that may happen. Here's a suspected adverse reaction to an occlusion. It's a catastrophic vertical fracture to the tooth. And when we mark up the contacts, the two incline contacts of that occlusal contact on that tooth, it's probably no great surprise that in a patient who was parafunctioning that it resulted in that catastrophic event. Malocclusion in terms of TMD, well, I talk to quite a lot of audiences on TMD, and there's usually one or two people who've come to tell me in the audience how much more they know about this subject than I do, and that's fine. I like an argument as much as the next person. And so if I have somebody who's really going on and saying, of course, malocclusion is the cause of a temporomandibular disorder, I put up that slide and say, well, if you're so sure that you can tell that it's a TMD patient by just looking at their occlusion, which of those 6 slides came from the TMD clinic and which didn't? And of course you can't do that. And the literature will support that as well. And I don't leave these up for very long because, as I say, I'm going to let you have the whole lecture as a PDF so you can look up those for yourself and come to your own conclusions. So I believe that there is no such thing as an intrinsically bad occlusal contact, namely a malocclusion. Only an intolerable number of times for that individual at that particular time in their life to function or parafunction on their occlusal contacts. So let's try, if we may, to adopt the term maladaptive occlusion, because it puts the patient at the center of the diagnostic criteria. Sorry. Beg your pardon. Oh. Pressing the wrong button, that's why. Right, second part of the talk. Occlusion in periodontology. I'm going to start with some definitions of occlusal trauma. I'm going to ask the question, does occlusal trauma have a role in the etiology of periodontal disease? And if so, do we think occlusal therapy should, at least in part, be part of the management of some patients' periodontal conditions? And then we'll look at some cases where I've treated people and there's been an occlusal element to their periodontal management. So some definitions. Periodontitis is the result of an interaction between a susceptible host and bacterial factors in dental plaque. We all know that, which exceeds the inherent protective mechanism of the host. That's the bit I want to concentrate on. So this interaction exceeds the inherent protective mechanism. Occlusal trauma is an injury to the periodontum resulting from occlusal forces that exceeds the reparative capacity of the attachment apparatus. So both of these processes, whether it's a pathological insult or a physical insult, seem to indicate that the periodontal tissues can't cope with the insult. There's definitely a similarity there, isn't there, between those two definitions. Let's just define another couple of terms. Occlusal trauma is a pathology. Trauma from occlusion, or more commonly called traumatic occlusion, is a force. So occlusal trauma is a pathology. Traumatic occlusion is just a force. So arising from that and our title, we've got two questions to answer. The first is, does occlusal trauma have a role in the etiology or the progression of periodontal disease? And secondly, if it does, should we consider some kind of occlusal therapy? So to answer the first question, and that of course is a research question, we need to look at the research. And there are three areas. There's the human cadaver studies, and that's literally a dead end. That doesn't give us any results at all. There's animal studies, and there's the human clinical trials, which are incredibly difficult to do for the lack of indices to measure occlusal force and occlusal frequency. So in truth, we are really left looking at the animal studies and to see what that information will give us. And in the animal studies, they look at applying two sorts of an occlusal force. There's the orthodontic force, the simple pushing, and there's the jiggling force, which is an intermittent force, which literally jiggles the tooth. You're familiar with the term fremitus. And then they applied those forces to three different sorts of periodontal tissues in the experimental animals. We had healthy periodontal tissues with normal bone height. We had healthy periodontal tissues with a reduced bone height, and we had plaque-induced periodontitis in these experimental animals. So what did we find? Here's a summary from a systematic review, and you can see there the orthodontic force and the jiggling force being applied to the three different sorts of periodontal tissues. And the overwhelming answer in terms of the orthodontic force, the pushing, is that it had no effect on any of those three different periodontal scenarios. So we can completely ignore that. Now let's look at the jiggling force, which is very much more interesting. And I've tried to give you my own table, which makes it, I hope, a little easier to see what the results are. So here we have got the effects of the jiggling force on the left-hand side, 3 different sorts of periodontal tissues. Healthy periodontal membrane, normal bone, healthy periodontal membrane, reduced bone, plaque-induced periodontitis. And we're looking at what happens to the periodontal membrane, to the mobility of the tooth, to the bone levels, and to the attachment. And let's go across on the first one. We get widening of the periodontal membrane with a jiggling force, healthy periodontal tissues and normal bone. We get an increased mobility, which of course is reversible. We lose some crestal bone height, but we don't get any loss of attachment. And there is no gingivitis. There's no inflammatory process going on. In the healthy periodontal membrane with the reduced bone, it's really exactly the same as the normal bone. Now let's look at the plaque-induced periodontitis. We get, again, widening of the periodontal membrane. We get an increased mobility, which is progressive. We get angular bone loss, and we do get loss of attachment. So the conclusion is that if there is a pre-existing plaque-induced periodontitis, the adaptive capability of the periodontal membrane is sufficiently reduced to induce the pathology of occlusal trauma. We've now got periodontitis and occlusal trauma in the same structures. So there is a little bit of work in terms of human clinical trials, but there's nothing really that you could call a good evidence base. So this paper by Nunn and Harrell said that teeth with an initial occlusal discrepancies had deeper pocket depths, worse prognosis, worse mobility than teeth without occlusal discrepancies, published in 2001. And then Hannah Bedis, who's a consultant in restorative dentistry at Leeds Dental School, her MSc was on sleep bruxism and overview, and she produced some evidence from the literature that said that bruxism may lead to masticatory muscle hypertrophy, tooth surface loss, fracture restorations in teeth, hypersensitivity or pain. We know all that, and loss of periodontal support. And there's the 3 journals that she submitted in her references to support that statement. So is there a strong evidence base to support the considerations of occlusal factors in periodontology? No, there isn't. Some of you may decide to go home now. That's okay. But we're not in the happy state, are we, that everything that we believe in is as a result of really good experimental evidence. And those of you who fancy a bit of a light, humorous read could do no better than reading the BDJ of 2003, when a paper was published that said parachute use to prevent death and major trauma related to gravitational challenge, systematic review of the randomized controlled trials. And of course they pointed out that there were no randomized controlled trials on the efficacy of jumping out of an aeroplane with or without a parachute. There is no evident base for the use of a parachute. And it's a great little paper because they managed to keep a straight face all the way to the end. And they say at the end, there are only 2 options. Under exceptional circumstances, we may have to apply common sense. And their second option, obviously tongue-in-cheek, those who advocate that only evidence-based interventions, they should volunteer for a double-blind, randomized, placebo-controlled trial of jumping out of an aeroplane with or without a parachute. So I would say that if we go back to the definitions of occlusal trauma and periodontal breakdown, the similarities in the results of both of those 2 pathologies are so close that it would be a good idea for us to consider in some patients occlusal therapy in the management of their periodontal disease. Obviously not solely, in the management of their periodontal disease. Because if you accept that an increased occlusal force, or just as importantly, an increased application of that occlusal force might result in further loss of attachment, we probably don't want that in the tooth that's already losing some bone as a result of the effect of the bacteria. It might be beneficial in the management of that patient to either reduce the forces or to redirect the forces in a direction where the tooth is more able to withstand them, or to reduce the number of times that that force is applied. But these are not mine or anybody else's rules. These are guidelines. It might be better if the force is reduced to less often. It's a cus-to-fossa relationship, and it's down the long axes of the teeth that are involved. So let me show you some cases where I feel I was justified in building in an occlusal element to the management of these patients' periodontal condition. I felt certainly that an occlusal analysis was appropriate. In fact, to be honest, I would do an occlusal analysis for every patient I see. So here's the first case history. This is a patient that's been following me around all my life because this is my youngest brother. And it's a story against me because I have literally been looking at his smile for a long time. And he phones me up, he lives about 200 miles away from me, to say, I've got this swelling, he describes it, I don't like the sound of it, and tell him to come up, we better have a look at it. So there's the swelling associated with the lower left second incisor. And we take a radiograph, and we were right to bring him straight up the M6 because there is a lot of bone loss around that tooth only. Any possibilities of trauma here? I told you it's a story against me because I've been looking at that upper left central incisor like that for a long time. And you can see that the way in which he's created that wear facet is by the parafunction of sliding, as I'm showing you in the bottom slide, of sliding his lower jaw forwards and to the left. So that is the incisor, the lower incisor. You'll see that his oral hygiene is no better than the sibling of all other dentists. That is the tooth that's lost the bone. So here's a patient who had definitely suffered periodontal breakdown, and this goes back a long time. I expect we were all a bit keener on doing periodontal surgery in those days than we are now. But I think it will show you what I'm trying to demonstrate. I'll make first of all the point that if you want to know whether a tooth is suffering from trauma from occlusion, and the opposing teeth are all a bit mobile, as you might imagine those lower incisors are, you've got to join them together in a passive position, because otherwise you will not see that. The paper will not mark that that is the premature contact, the lower left central incisor against the upper left central incisor. But as soon as you join those teeth together, they ain't going to move as they close together on the articulating paper, then we can see that is clearly the heaviest contact. So you have to get in, I think you have to get into the habit of temporarily splinting the teeth. And then when we took back at the flap, we can see that the bone loss around that tooth that was suffering from trauma from occlusion was worse than anywhere else. And so in that case, I was justified, I believe, in equilibrating the lower incisors so that the occlusal load was evenly shared between the upper and lower incisors rather than just on two of them. Here's a patient that was referred by their general practitioner to me in 1989, and that's, I promise you, that makes me as old as you think I am. And this was a patient who was born some 34 years prior to that, and her problem was that she'd got some loose front teeth. And she'd been advised that she needed to have all of her upper teeth removed by a periodontologist at the Manchester Dental Hospital, and that didn't go down well with the patient. So we did an examination for this patient, and those are the teeth that are present. The gingiva, a bit red, but no bleeding. Fantastic oral hygiene. Bone loss was bad, about half, 50% of bone loss, and the upper right second molar had a trifurcation involvement. So prognosis is not good, and you can see that's why the periodontologist gave the patient the treatment plan that he did. So here's the radiographs from that initial examination, and this is a 34-year-old patient. So when it's not a happy state of affairs, several teeth were mobile. So we did all the normal stuff that you'd expect, pocket measurements. We also looked at the occlusion and found that centric occlusion wasn't in centric relation. The premature contact in centric relation was between the upper right 8 and the lower right 7. And there was also a non-working side interference between those teeth. And generally the patient had got posterior support. So the treatment plan was, number 1, the stuff that you'd expect, and number 2, to equilibrate the patient's teeth so that the centric occlusion did occur in centric relation, that is to eliminate the premature contact in centric relation and all the posterior interferences, and then the periodontal surgery and then a full mouth restoration to balance out the occlusal forces. And that's what was done. I would like to point out it's not my bridge work on the lower right. I did make a little precision attachment, again showing my age, on the lower left. And we gave the patient a balanced occlusion. So in April of 2020, this very severely compromised tooth on the upper left needed root filling. We had a perioendo, that didn't help things, but it's still there. I mean, that's a photograph from 3 years ago nearly, but I promise you it's still there. I saw her earlier this year before lockdown. Things on the upper right were not particularly good because somebody in doing some root canal treatment, silver points, I didn't do those, I'm not that old, had also perforated into the furcation region. That didn't help things at all. But I want you to look at the bone level on the upper right third molar, and this is now the year 2000. And eventually we had to give up on the second molar, and we didn't have to take it all out. We kept some of it. But let's go look in particular at that third molar again. There's the radiograph 1987, and there's the radiograph from 2011. There's no further bone loss. And the tooth is not mobile. I saw the tooth, I saw the patient this year. The photograph I'm showing you there is from 2017, but that tooth is not mobile. So my conclusion is that the periodontal membrane is a wonderful piece of kit. And if we make life a little bit easier for it, it is amazing what it can do. So the patient still has a functioning occlusal contact between that tooth, which the periodontologist believed in 1987, or maybe a year or two before then, had a hopeless prognosis. So here's a patient who had some very ill-fitting crowns, and we were going to do some crown lengthening to try and sort it out. And we found with horror, when we took back a flap, that there was an enormous external resorption. Now that, of course, is an adverse reaction in the gingival tissues, because the effect is on the tooth, but it's the inflammation in the gingival tissues that causes that. And you can see how huge that was. So we did a bit of a repair in some glass armor there and sutured it up and hope things got a bit better, which they didn't in the long term, but they bought us some thinking time. But what's the etiology going on here? Why was the gingival inflammation around that upper right central incisor so bad that it caused an external resorption? And there's the clue. We all know, don't we, by looking at the palatal aspect of that crown, that when that crown was fitted, it was high. In fact, even after all that adjustment, it was still high. And there was marked fremitus on it. So I think the occlusal load to that tooth was beyond the patient's adaptive capability, beyond the periodontal tissue's adaptive capability. That was a maladaptive occlusion. Here's a patient who was referred for some implant replacement of some mobile and purulent teeth. So this at significant levels of periodontal disease, which especially marked on the upper right central incisor. Remember these teeth, if you will. The upper right central incisor, the lower left 5, and they had lots of bone loss. And the upper right 2 was also a bit mobile. So occlusal examination is part of the overall management of this, even though the patient is accepting the idea that these teeth have had it and now I need to have some implants. Centric occlusion is not in centric relation. The premature contacts are on the left-hand side. There's a slide, and then there's trauma to the front teeth, especially the upper right one, and there are some incline contacts. So part of my program here would be to make some mount some models which are mounted both in centric occlusion and centric relation. And it's quite interesting when we look at the centric occlusion models. I use a thing called an occlusal sketch. There's lots of other ways of recording the patient's occlusion. But if we look at the occlusion, the clinical record of the occlusion on the occlusal sketch, the blue marks are static occlusion and the red marks are dynamic occlusion in both their and models. We can immediately see there's some differences in the models and in the mouth. And that's going to help us with the diagnosis here. The diagnosis is going to be occlusal trauma. So there's the 4 differences, 3 of which I think are pretty obvious. So in the mouth, all of the palatal aspects of all of the upper incisor teeth had occlusal contacts, whereas on the models, only one, the tooth that had the worst bone loss and purulent gingival tissues. And then we're looking at the upper right lateral incisor. And now the difference is in the dynamic occlusion, because on the models, there's a clear dynamic occlusal mark, whereas in the mouth there wasn't. And it's exactly the same on the lower left second premolar, number 3 down there, exactly the same. And of course, the reason for that is that the models are fixed and solid and the mouth isn't, that these 3 teeth to some degree were mobile, and therefore when I examined the occlusion in the mouth, I didn't pick up the fact that there were a traumatic occlusion on them, whereas on the models it's clearly obvious. So that's a situation where an occlusal analysis, albeit in the mounted models against the comparison of the occlusal record in the mouth, is actually diagnostic. It's a matter of just interest, number 4, because in number 4 it's the other way around. In the mouth there was a dynamic occlusal mark, whereas on the models there wasn't, and that's our good old friend Bennett movement. Okay, or as it should be called, immediate non-progressive side shift. So it's that kind of thing. It's not a lecture on that. So there's some examples where there was an occlusal element in the in the management of their periodontal disease. Let's look at a little bit more detail at equilibration. So when we're going to equilibrate somebody's teeth, it's not spot grinding. It's trying to create a centric occlusion that occurs in centric relation with tooth contacts that are cusp, fossa, and down the long axes of the teeth, and the anterior guidance is at the front of the mouth. For me, always do a mock equilibration first on some accurate study models, and always do it in the mouth with 2 visits. And it's not, as I say, spot grinding. You're not going to destroy it. So here's a mock equilibration. You set off with 2 sets of models identical to the patient's occlusion and identical to each other, because we're going to ask ourselves, can centric occlusion occur in centric relation for this patient? In the premature contact in centric relation, these models are mounted in centric relation, is just there. You can see it very clearly, just 2 teeth are involved in it. There's the premature contact. And by marking the models and making some small adjustments, which I'll try and demonstrate to you, or at least Shilpa will try and demonstrate to you in a minute or 2, we can take us through very quickly a situation where we're getting many more contacts Of course, the joy of articulators is that they can be locked into centric relation. So after a very short period of time, suddenly now we've got everything touching. And we can then go to the mouth and do exactly the same there with a great degree of confidence that it's going to be achievable. So always equilibrate, mock equilibration, model equilibration first, and always do it over 2 visits.
Okay, so my name's Shilpa and I'm going to talk to you about one of the patients that we've been seeing in our TMD clinic. It's a real life case study that's ongoing at the moment. So initially our patient presented to us with myofascial pain, and this was diagnosed in the TMD clinic, and we made her a stabilisation splint, which worked really well for her and got rid of all of myofascial pain symptoms. And we then tried to wean her off this stabilisation splint, but unusually her symptoms came back after trying to wean her off the splint. So we've had a discussion with the patient as to what we can do for her, and we've had a discussion to see if there was a possibility that we could make her centric occlusion in centric relation. So we brought the patient back and took some copies of some study models. So we had 2 sets of study models, and we did a centric relation record as well. And these are the study models here that we have, which show that there is a premature contact in the palatal incline of the upper left premolar, which corresponds to the lower left premolar as well. And you can see that there's a buccal cusp there, so that's the premature contact that's marked. So we're hoping to eliminate that premature contact and give her a balanced occlusion, and make things more ideal for her so that she can tolerate her teeth as they are without the splint. So we took 2 sets of study models, did a centric relation record, and once these models were there, we basically do a mock-up equilibration, which is where we are slowly taking off, adjusting these models until we get even contacts and we get our centric occlusion. So this is the articulated study models for the same patient, and we're starting, things have come a long way. I've already started working on these, and we've basically now got contacts on almost all of the teeth. In fact, we have got contacts on all the teeth apart from a partially erupted wisdom tooth. But you can see that actually, having a look, there is still quite a heavy contact here, so that will be the next area that we need to adjust. So I'm just going to adjust that now to show how it's done. So we use a Lacron instrument, and we just take it here and adjust that incline so that we are getting a nice contact on the cusp tip or the marginal ridge. Okay, and you can see that heavy contact there, that was on an incline, which is what we don't want, was corresponding to quite a buccal contact on this lower premolar. So again, we'll just adjust that slightly. Okay, so we'll mark that again with our articulating paper. Let's see how it's looking now. So it's not marking there at all now, which is good, and we're getting our markings on the cusp tips just there, which is exactly what we want, and we've eliminated that buccal contact there. Okay, so we just carry on doing that until we get a completely even centric occlusion.
So there we go. So that was Shilpa actually doing her very first mock equilibration at the dental hospital for that patient as she described. And it was just a little snippet towards the end of the process, just so hopefully you could get some idea of what we're trying to do. Now, can this have an effect on patients? Well, we're very lucky to have Beverly, who has agreed to tell dentists the effect it had, and I'm grateful for that. every time I hear it, I'm a little uncomfortable with one of the phrases that she uses, namely occlusal happiness. But Beverly had a situation where she had an adverse effect, adverse reaction to her occlusion on the articulatory system level. She had myofascial pain on the tooth level, on the periodontal level, and there was a possibility that she'd had this for so long that she was becoming occlusally hypervigilant, which might suggest that she had the adverse effect on the cerebral level. But as it turned out, she didn't, but it's a difficult decision to make when you first meet a patient. So she's going to spend a few minutes now telling you this, and I would be very grateful if nobody records this in particular.
Hi there, I'm Beverly, and I've put this short video together to share with you my journey in finding occlusal happiness. But a bit of background information first. When I was 11, I fell off my bike and landed on my front teeth. Unfortunately, my upper right central tooth was broken and I had a post and crown inserted. Over the years, I've had this crown replaced twice with no adverse effects on my occlusion. However, when the crown needed replacing 3 years ago due to a receding gum line, I could never have imagined that this relatively simple procedure could cause me such discomfort and anxiety. As soon as the anaesthetic had worn off, it was very obvious to me that my resting bite was badly affected, mainly because the newly fitted crown was too bulky. I tried to persevere with the situation, thinking that I just needed to adjust to the new crown. However, when your bite is off, it's a constant irritation and one that's very hard to switch off from. It can be really quite debilitating. My symptoms deteriorated fast and I experienced numbing around my nose and upper lip and a tingling sensation in my cheeks. These symptoms were probably aggravated by the fact that I grind my teeth and clench my jaw when I'm asleep. And because my resting bite was misaligned, I was now putting extra pressure on my back teeth, causing quite bad jaw ache. As I couldn't tolerate the discomfort any longer, I made an appointment to see my dentist, and he was very doubtful that the new crown could be causing my symptoms. However, when he could find no other cause, he proceeded to reduce the bite against this new crown. I felt instant relief, but was dismayed at the appearance of what was left of the crown. As my dentist was so reluctant to replace the crown, and given the bad experience I had gone through, I felt I had no alternative but to find a new dentist. To cut a very long story short, during the next 2 years I went through several dentists, several temporary crowns, one permanent crown and an NTI splint guard that only served to make the jaw ache much worse. On the recommendation of a doctor friend, I made an appointment to visit a dentist that specialises in occlusal trauma with the hope of remedying the issues I still had with my crown and bite. After this dentist's initial examination, he produced a report for me stating that there were signs of occlusal trauma on the crown, the other front teeth, and also against some back teeth. These signs included bone loss around some of the teeth, particularly the 2 upper back teeth. The treatment plan was long with lots of different stages before I could have my new crown. Obviously, there was treatment for my periodontal disease, but unfortunately for one of the back teeth, this came too late and has now been extracted. In terms of the treatment plan, the first part involved making a bite splint which was very carefully balanced over several visits. I jokingly refer to this as the Hannibal Lecter device because of the face bow used by my dentist to create it. This splint has now resolved all of the jaw ache that I was experiencing, which is great news. It has also reduced the wearing down on the enamel on my bottom front teeth from the severe grinding I do when asleep. The next step was to take some more impressions and then use the Facebook device again to make a study model to determine whether it would be possible to equilibrate my own teeth. My dentist showed me on the models that this would be possible, so we proceeded to have this work done too. When my dentist finished his life-changing occlusal work on my teeth, I actually broke down in tears at the relief of being able to close my mouth comfortably in a resting bite position that actually felt restful. Looking back, I wish that more dentists fully understood the impact that restorative dentistry can have on a patient's occlusion, and to be more understanding when the patient is having problems with their bite. On several occasions during my search for the right dentist to help me, I was made to feel like a hypochondriac, which only serves to damage the trust between dentist and patient. I only wish that I had found my current dentist sooner, because based on my own personal experience, the importance of balanced occlusion should not be underestimated.
So there are many bits of that which I wish you haven't said, but I think it's a valuable message for us all, because she felt some significant benefits. Maybe I ought to take that out of a lecture on periodontology, because for one of the second molars it did come too late. It was a non-working side interference, and it had lost a significant amount of bone, and it wasn't able to be as successful as we had with that previous patient. So to do a mock equilibrium, I put it in there because I want to encourage you to pursue your studies so that you get these skills. And I'm quite sure that Tips and Training will be able to fulfill that, and other places will be able to fulfill that for you. You shouldn't be frightened about making adjustments to some models. You can't do any harm by adjusting some models, and you'll learn an awful lot when you do it. So you won't need very, I'm starting at the bottom of that list, you won't need very long. Classically, I do these over lunchtime. You need some articulating paper, a Lacron carver, and 2 sets of verified, accurate study models. And so there's the premature contacts for this particular patient. And then after 10 minutes, we've got to there. And after 20 minutes, we've got to there. And that indicates that it is going to be possible. And I think if you look at those teeth, you're not going to see a big difference between their shape before and after. It's all very, very minimal adjustment. Right, so let's look at some particular cases. And I expect I'm showing you these cases now because I want to encourage you never to give up on the periodontal membrane. So there we have a perioendo, and lots of thoughts are flashing through our mind now. Take it out, put an implant in, maybe take it out and put a bridge in. So that's what we had. Well, I try not to give up on the periodontal membrane, and the periodontal membrane around the mesial root of this lower first molar looks pretty good to me. So let's think about heavy section. We do some endo on it and take out the distal root, and look at the dates, if you will. That's the presentation in May 2011. And by June, we've done that. And then in March of 2012, we've left it for a while, and everything seems to be going pretty well okay. There's a temporary restoration on that tooth. Yeah, there's the temporary restoration. It looks like the third premolar, doesn't it? It's composite. That's May 2012. So there we are. That's the chronology. And then finally, we get to put a gold crown onto that mesial root when in November of 2014, we've decided that everything is okay. There now follows a party bellical broadcast on behalf of shimstock. So I'm a great believer in shimstock, as I'm sure your tutors at Tipton Training are as well. It's easily the most accurate way of determining whether the occlusion is high or not. And here's my dental nurse holding the articulating paper against the crown. My dental nurse is my occlusal prefect. She's in charge of occlusions. She tells me when it's right and it's wrong. So it looks like it's pretty good. Obviously, we haven't polished the surface of that crown yet, but it looks like it's a pretty competent occlusal contact. And then the shimstock goes in and it pulls out. The shimstock goes in on the other side, and when the patient's closing together, it pulls out. Because the shimstock is only 8 mu thick, because the paper that I use is 40 mu. I know you can get thinner paper than that, but I feel I don't need to because I'm using shimstock so much. So it must be high, and then after a very small adjustment, it still is in occlusion. It doesn't look there's any different. You can see that the shimstock is now held. So please, if you're not using shimstock, get it out on every bracket table whenever you're doing a restorative procedure. So here's a bridge that is spanning from the mesial root of the lower first molar on the left-hand side through to the second molar, and the distal root is now replaced. The distal part of the tooth is now replaced by a pontic. So here's a patient, and you can see that things aren't looking too good there on the top. I've circled, and initially we did manage to do a reasonable repair of that, and then Sod's law works as well in dentistry as it does in anywhere else, and Sod's law meant that he got some either external resorption or caries in the bifurcation area, and Sod's law is working quite well here because this is my first boss at the Manchester Dental School. He's a now retired consultant oral max-fax surgeon, and I'm trying to take out the distal root, having decided that a hemisection was the best way to go. And I had to say to him, Alan, I'm really sorry, I can't get it out. I'm going to have to take back a flap. And he said, why? And I said, because I can't take it out. He said, no, why? Are you trying to take it out? This is an oral surgeon telling me to leave a root in place. So he quite rightly guided me into what I should do, take it down to the crestal level of the bone and suture the gingiva across the top of it. And that's what it looked like. So there's a root in there and it's working perfectly well. One of the good things is that if you have to cut a gold crown in half, amalgam sticks to the gold really well because it forms an amalgam, a gold amalgam as opposed to a silver amalgam. So here's another case, and we do two hemisections here on the lower jaw. And those teeth aren't joined together, and they've been like that now for a very long time, and they're perfectly okay. Also did a root resection on the second molar on the upper jaw, which is much more difficult. It's technically not as easy because you're dealing with a tripod. And we did do some treatment to provide him with some occlusion on the other side. But as you can see, everything is looking pretty good. No, there's no mobility of the teeth at all. Sometimes we don't bother restoring them. That's a section of a tooth, and we just have restored it. Sorry, sometimes we don't bother crowning them. That's just a composite restoration, which is providing good function for the patient. So let's think a little bit about stabilization splints, and I have been doing this for a very long time because that slide down there at the bottom is a slide when I looked at it's an old-fashioned transparency. When I looked at the date on it, it was 1980. Yeah, 40 years ago. So there's a stabilization splint. And a stabilization splint is a removable ideal occlusion, going back to Ranford and Ash's definition of 1983. So I'm not going to spend any time talking to you about stabilization splints, except to encourage you to learn how to make them. So there's one going through the process of balancing out the occlusion. It's actually got group function on one side and canine guidance on the other side. So a different sort of splint now. What's a periodontal splint? Well, a splint is, I'm going to sneeze, sorry. A splint is a medical device to keep injured body parts from moving. It's to stop movement. So the indications, I believe, for a periodontal splint are very severely compromised support due to advanced periodontal disease. They are not to resist trauma from occlusion. You need a very well motivated patient, and the patient has got to understand, I haven't made your teeth any stronger. They're no more attached to the bone than they were before, but because I've joined them together, they will feel stronger. And in terms of doing it, I try to always do it under a rubber dam and fit it under a rubber dam. And it is after an equilibration has been done to minimize any trauma from occlusion. And that will involve temporary splinting first. So here's a case where we've used some Ribond. The other one is Stick Tech, which is a kind of fiber material which can be adhered to the teeth. It's all very neat and easy to use. Well, actually, it's not very easy to use, but it's worth learning how to use it because it can be a real, not lifesaver, it can be a real tooth saver. And it can look pretty neat at the end of it, and it's just a one-visit procedure that. So it's in place. And you can see, you can just about see it from the labial view of those teeth. But the important thing is those teeth will keep still now while the patient's cleaning them. and that will improve their oral hygiene, and that will reduce their tendency to further periodontal disease. There are other ones. There's the ortho wire splint. I don't find them quite as neat as the Ribond, but they work as well. And there's a ortho wire at the back and Ribond at the front. So to prepare a metal cast splint, which is a bigger job altogether, I like to do preparation. Some people don't mind not having a preparation. I just find it better because the technician knows exactly where to end the and start the abutment. So I'll put the temporary splint on first, on labelly, to keep everything still, stick the rubber dam on, prepare it, and then fit it. And that's a photograph that I took just immediately after it's fitted, and I want you to compare the gingival tissue within about, I think a couple of weeks, yes, 2 weeks later, see how it's improved, just simply because the splint is enabling the patient to adopt a higher level of oral hygiene. And this is what the patient says about it.
Hi, my teeth used to be very loose and wobbly. I found it very hard to clean them. Consequently, I used to get a build-up of plaque and gum disease. Now, since I've had the splint fitted, I can clean my teeth easier and the gum disease has gone away. In fact, my dentist and hygienist both speak to me again, so I would definitely recommend the splint.
You can see you never have total control of what patients are going to say. This is what the hygienist said.
I treated a patient who had been fitted with a lower anterior perio splint. Prior to the patient having the splint fitted, he struggled to effectively clean his teeth, both with a toothbrush and any incidental aids, which have resulted in the patient's gingiva becoming very inflamed. There was bleeding on probing and pocketing present, and copious amounts of calculus, both sub and supragingivally. The patient attended for RSD under LA, and in conjunction with that, I used dentamycin. 2 weeks later, I reviewed the patient and placed the remaining dentamycin. Within that 2-week period, the gingiva appeared much healthier. The bleeding on probing had reduced, and so had the inflammation. Patient compliance was great at home, and he felt he could really give his teeth a good clean, especially around the gingival margins. The patient was now able to use a selection of TP brushes and his water pick very effectively. The patient was very happy with the results and will be back in 3 months' time for further indices and a routine scale and polish.
So you get the idea. This is a splint I did it's more than 20 years ago now. It's probably 30 years ago. And that's got some Pontics in it as well. So it's worth you looking at some of those patients and thinking, yeah, I wonder if I could just say, especially lower incisors, because they are just the most disastrous teeth in the mouth to lose, aren't they? And this particular splint also supports a cobalt chrome denture. So my take-home message, and thank you for your patience. We're just approaching the hour and a half, and so thank you for your patience and perseverance. So my take-home message is never give up on the periodontal membrane. If you can improve its circumstances, and I'm particularly talking about the occlusal circumstances, it's amazing how much it can repair. It won't restore back to what it was, but what is left can probably do a better job than we give it credit for. I hope I've given some scientific indication, as opposed to evidence, that there is justification for this approach. But even if I haven't done that, I can tell you through personal experience that I've been surprised how well a compromised periodontal tissue can do. And I'll finish off now with something with a colleague of mine, actually not in the practice I'm in anymore now, but that's another story. And if you think you're having a bad day, just consider what happened to this in this surgery. So we have a patient who in the car park chose the wrong gear, and instead of reversing out of the car park, drove through the wall of the surgery. Thank you for your attention. I'm very happy to take questions. I think Louise is going to help us with that. And Oh, my email address isn't up there, but it is on other slides, and I'm very happy to take questions other than just now. But so, Louise, if you're still there, I'm going to come out of this now.
Yeah, I think there's a couple of questions in the Q&A, Stephen, if you could.
Right, that's good. Let me just get out of that. Right, where am I going to find these questions? Is it the support chat that I'm looking for, Louise?
No, it's just in a Q&A box at the bottom of the Zoom.
Oh, right. There it is.
Yeah.
Thank you very much. Which came first, the bottom or the top? Let's have a look. Oh, the top one.
The top, I think,
yep.
in my order.
Yeah. Okay, what you're just asking the patient to bite on about the thickness of 2 tongue spatula. So we take a tongue spatula, we break it in half, and then we ask the patient to bite on the thickness of those 2 bits of wood. You could use almost anything. It's got to be fairly firm. I wouldn't suggest a piece of metal, but tissues wouldn't work. The key thing to do with this, remember, it's called the compression test. So if I am biting between my back teeth on the left-hand side onto a piece of wood, which temporomandibular joint is being compressed? It's the one that doesn't have the support of the bits of wood. That is on the other side. I said they're biting on the left, so it's the one on the right. It's the joint that you're compressing. And if you're compressing that joint and it elicits the pain that the patient is describing, then it is a pain that is probably coming from within the joint, that is to say, arthrogenic. Whereas if the pain is on the same side that you're biting on the bits of wood, it's because the muscles on that side are working a little bit harder to try to get to bite through the wood, and that's suggestive of myogenic pain. I have an allergic reaction to dentists saying, would you please see this patient who's got TMJ pain? Because I'm going to say to them straight away, how do you know? What they're describing is pain in the preauricular region in front of the ear. That could well be coming from the lateral pterygoid muscle. So this is a nice, useful way, together with the resistant movement test for the lateral pterygoid muscle, of determining whether the pain is arthrogenic or is myogenic. I hope, Shaza, that that's answered your question. And if it hasn't, you can tell me. And the next question I'm going to go to is, how do you transfer the occlusal adjustment on the articulated study to the patient's mouth? And the short one-word answer to that is carefully. It's a huge advantage that you've already done it on the models. The first 2 or 3 dozen of these cases that you do, you will write down like a script. You'll write down what you did on the models, and you'll find that for the sort of first 10 to 20 adjustments in the mouth, you'll do exactly the same. After that, it becomes a little bit less vague, but after that, it doesn't matter because you can see the promised land and you know where you're heading with it. But it is the fact that you've done it on the models that means that you will be able to do it in the mouth. So you'll be anxious. It's strange, isn't it? If I ask dentists to do that exercise, they'll be ever so anxious about it. But if I ask them to prepare a 3-unit bridge, they'll go straight away and get the biggest diamond burr they can and have no anxieties. So it's a good question, and give it a go. All right, the first few you don't have to go through to do it in the mouth. You just need to practice on some models, and you'll find it becomes intuitive. It works. So Maxine, well, it's just very nice, Maxine. It's not a question, it's a compliment, and I'm always ready for them. So I hope you're well in Zambia, and thank you very much for your kind attention. So, Lillian, please, while examining the patient to check if CO is equal CR, at what position is the patient placed? Okay, good question, very good question. I did show it happening, and it's not a lecture on that, but if it was, I'd be showing you more detail. For me, I find it's easier for the patient to be lying down. You do most of the other procedures you do for the patient with them in a supine position, so this doesn't need to be any different. I have the patient lying down. I have their head roughly at my elbow height. I need to be comfortable, fairly relaxed, because I'm looking for a muscle-free position, and it's no good me supervising, substituting my muscles for theirs and thinking that's muscle-free. So then you just take hold of the mandible, you try to get the patient to relax a little bit, and you can feel and see that the mandible is just arcing in that perfect arc, indicating that you're in terminal hinge axis, another way of saying in the rotational phase of movement. And again, it's just one of those things that you have to just do a few of. So start grabbing your family members, staff members, colleagues, and just getting a feel for finding it. All right. I've done Charles's question. Maria, I did not understand how you transcribed from the models the occlusal spots with the Lecron. I do not understand. So what you're doing with the Lecron on the models is that you've marked up the occlusion. You may see that there clearly is some occlusal marks that are heavier or maybe exclusive to all other marks. What you don't do is cut off or grind off the top of the cusp. You're trying to get the cusp tip to fit into the fossa, which is another way of saying you're trying to eliminate the incline contacts. And by making the fossa slightly wider and the cusp tip slightly sharper, you'll suddenly find that it starts to interdigitate. When you're looking for stabilization of the occlusion, I'm not sure I understand. Well, obviously it's a stable occlusion if all of the occlusal contacts occur at the same moment and there are no incline contacts, and if possible they're down the long axis of the teeth. I'm sorry, Maria, it's really difficult to answer your question. If we were sat opposite each other on a table and we had some models on an articulator in front of us, I could show you it in seconds, as I'm sure you'll find other mentors who could. But if you're not in a position where you can do that, then just get some models, and I think you'll find that it will become obvious what you do next. That looks like, Louise, all of the questions, unless you can see any more coming up.
No, I think that's it, Stephen. Yeah.
Okay. Well, again, thank you for everybody from taking some time out of their day, and all the best to all of you. Okay.
Thanks ever so much. It was a wonderful webinar, Stephen. Thank you very much.
Well, you've listened to 2 webinars today. You must have a head.
I know. I've been in for a treat.
No, I'm not sure it's a treat, Louise. I need to say, you probably need to go off and lie down in the dark room somewhere.
Thanks ever so much. Take care.
Bye for now.
Bye-bye.
Bye-bye.